Share.
Okay, so now it seems everybody's know this now. So some of the extra renal manifestation includes polycystic liver, subarachnoid hemorrhage, which is what Emilia Clarke from Game of Thrones had twice, and subarachnoid hemorrhage, and then you can also have a mitral valve collapse as well. These are the different manifestations. So yeah, okay. Then yeah, as in like, okay, there is also, so this one, the adult version is called autosomal dominant, and there is a kids version which is called autosomal recessive, and it's kids only because these kids don't survive past childhood. Okay, so that is for PCKD. And then with urothelial carcinoma, so this is associated with occupational exposures. And okay, I think like the occupational exposure is going to be organic chemicals. I'm sure when you do your Desmond Price, you're going to be all over this. Okay, just remember that urothelial carcinoma can present with painless hematuria, and they are usually with those who work in like in slightly different occupations. Okay, so and then okay, yeah, so that's what I'm going to say. So with renal cell carcinoma, again, it's a pathology thing. So you're going to have clear cell papillary and chromophobe. Oh, sorry. Okay. Okay. Then, so there is a few differences. So I've just summarized your clear cell papillary and chromophobe. So it goes in order of decreasing frequency, but increasing prognosis. Okay. So that's just something to take note of. And if they say that like this striking tendency to invade the renal vein, if you do some of your Rubin's and Lippincott pathology questions, this is exactly what they ask as well. Yeah, so you get a mass. Okay, any questions regarding any of the masses in the kidney? So there is another one, like you may have come across, it's called Wilms tumor. So that is a condition that affects children, and it's Wilms tumor. And then like yeah, so there is, but don't worry, like this, you will learn this in next year as well. Okay. Urology. Okay. BPH and prostate cancer. So prostate cancer is what all the urologists love. I'm sure they have talked to you heaps about PSA screening and how useless it is. But okay, so with regards to BPH, the main okay, so there's a few things they'd like to talk about. So BPH and prostate cancer. Tell your friends, where do you think the lesion is? So like which area does it affect more? Sorry?
Just ignore me. I'll speak jumping up and down.
Oh, no, that's fine. Okay. Okay, the food is here. Come on, guys. Last 10 minutes. Oh, no, last few minutes. Okay. All right, so now I'm sure everyone's like, I'm hearing central and peripheral. So central is going to be BPH and peripheral going to be prostate cancer. The way I think of it is BPH always presents with symptoms of your lower urinary tract symptoms. So there's going to be a frequency, urgency, nocturia. So these are your storage symptoms, and the voiding symptoms is, think of them as pre, during, and post. So pre is when you have hesitancy, so it's difficult to get your urine stream going. And during is when you've got what we call terminal dribbling, weak stream, and a few other things. And then post voiding is when you got this thing where you just had a urine and then you want to go again. So that's called piss and dukes or something. Okay, so okay, and then like I guess your international prostate symptom score is another questionnaire that to evaluate how severe his symptoms are. And what is the surgical option for BPH? TURP, beautiful, and that's the one with shaving, with shaving. Okay, and then in terms of medical management, you've got tamsulosin and what we call the alpha-1 antagonist. Okay, so this one helps to open up your urethra to allow for better like voiding. So okay, so with prostate cancer loves to go to the bones. Okay, and with regards to some like when I think you guys just have a pathology quiz on Monday, is that correct? So with that, like are you guys covering bone this time? No. Okay, so with bone one, maybe I'll just talk about. So there is a bones like tumors in the bone is almost always metastatic. And with metastatic, you've got osteoblastic lesions and osteolytic lesions. So and none of this is a direct effect of the cancer. The cancer secretes some molecules that will result in the dissolving of the bone. And I think like in terms of classification wise, the one that causes osteoblastic lesions is going to be prostate. And your breast, kidney, and other cancers can result in osteolytic lesions. So this is something to maybe it will help you guys on Monday. Okay, then with regards to the way on examination findings, on your BPH is going to be a smooth, enlarged prostate. However, this one you're going to find some nodular prostates as well. Okay, so yeah, I'm sure you guys have heard of Gleason score. So just take note, there's always a difference between grading and staging. Grading is how weird the cells look. Staging is how far they have gone down. So with staging for prostate cancers is again T&M staging, but with grading you've got Gleason. So Gleason, how they do it is a score out of 10. So you take two weird looking cells. So you find all the cancers. Prostate cancer is a heterogeneous disease. So some is very aggressive, and then you've got some bits that are least aggressive. So you find the two most aggressive ones, you grade them, and then you add the score together. This was the old way they did it. I think on exams, this is what they expect you to know. But there is a new one, and they've got, I think it's International Prostate Society or something. They've got a new way to classify this, but we just stick to Gleason for our exams, okay? And yeah, any questions regarding that? Okay, so with prostate cancer management, it depends on the grade, of course, grade and stage. And with regards to, okay, so with prostate cancer, they always like to talk about you will never ever die of prostate cancer, you die with prostate cancer. That's because even after you got diagnosed with prostate cancer, you can live another 15, 20 years. So, and that's the reason why they say that. And what you want to do is you want to do androgen deprivation therapy. So the first thing you want to do is you want to do a chemical castration. How you do that is you do a what we call a GnRH agonist therapy. I think they call it, no, is it Prolia? Okay, okay. So there's like lots of patients are in. So on GP you see a lot of patients, and after that has failed, then you do a surgical castration. Okay, so that is what you go down for your metastatic prostate cancer. If it is still resectable, you obviously resect it as well. Okay, and yeah. Okay, so that was it for the renal ones. But are you guys hungry, or do we want to just have a brief overview? Continue. Okay, continue. Okay, so with inguinal masses, like I think this is something that can come out in the exams, and it's always a bit confusing. It doesn't fit anywhere. It's not. I don't know whether it's like you learn it in surgery or in renal. So there is femoral hernia, inguinal hernia, and psoas abscess, and a few other things. So with lipoma, something that you learn in year 3 is this thing called a slippage sign. So that's just a benign enlargement of the fat cells, and you get lipoma. You can get this anywhere, and it's benign. With Saphana varix, it's a common differential for inguinal hernia. And like cough impulse is basically when you cough, you increase your intra-abdominal pressure, and some of these lumps will enlarge in size, and then it will shrink back again. So this can happen with both Saphana varix. So if Saphana varix is a varicocele essentially, so it's a dilation of the vein, or you can have hernias. Hernias is when you've got inguinal hernia, your intestine is coming all the way down through some of the a defect in your anterior abdominal wall, and then it will enlarge and shrink after a cough impulse. So femoral hernia, high risk of strangulation, and I'm sure there is naval and a few other mnemonics you use to remember this. Just highlighting that to you guys. Inguinal canal, so there is direct. Okay, so I think with regards to femoral hernia, is usually medial to the pubic tubercle, and inguinal hernia is lateral to the pubic tubercle. With inguinal hernias, you've got direct, indirect. Direct is medial to your inferior epigastric, and indirect is lateral to your inferior epigastric. Okay, so I've just talked about this. Okay, so this is tough, man. Okay. Okay, I think like some of I can say a lot of things, but it would be useful to go through the surgical anatomy and then like understand in your own. Okay, scrotal sac. Oh, so have you done scrotal sac?
Less so.
Okay, sure. So scrotal mass. So you've got pain. I will split them up into painful and non-painful. So the one that I can think of most of the time is testicular torsion and epididymal orchitis. So and with testicular torsion, there is a minor one which is called torsion of the testicular appendage, and then you also got a strangulated hernia as well. So yep. Then the non-painful ones is all buzzwords. So we will go through them. Okay. Testicular torsion is going to be a surgical emergency, and it's basically a twisting of the testicles because ischemia and therefore swelling and lots of pain. So classically, they will. I think there is 2 points where it becomes common. One is in puberty, where like their testicles becomes a bit heavier, and then the other one is very early on, and when they're just jumping around, playing around, and that causes a twisting of the testicles anyway. And yeah, so and then is a testicular pain that radiates to the umbilicus because there is T10 innervation. Okay, that is the basis of all this. And the risk factor is a bell clapper deformity. So that's just bell clapper deformity is basically it predisposes them to twist and therefore cause ischemia of the testicles. So this one, if they say what is the next step in management, don't do an ultrasound, just send them to the surgeon straight away. Okay, so that's something that comes up often. And then when you do a surgery, don't just fix one, fix both, because you don't want this to recur on the other testicle. And okay, varicocele. So the way I was told is you've got a pain that is very similar to a vascular pain. So if you get a myocardial infarction, so they feel that someone, like the elephant is sitting on their chest, so that's a pressure sort of pain. It's a similar pain for a varicocele, and the pain is in the testicles, and it feels like a squeezing, aching pain that is worse after standing for a long time. So maybe they're working in a retail shop and they've been standing the whole day and then they lie down and it gets better. That's a varicocele. And this one, your nutcracker syndrome, it might be useful to know. So with your left and right testicular pain, this is more common in the left. And in the left, if it keeps occurring, you might want to think of a tumor that's obstructing your left renal vein. All right. So okay. So any questions regarding then like what's my varicocele? Okay, sorry. Coming to the end. So hydrocele is basically nothing but it's a swelling in your like with fluid, and that will trans-illuminate brilliantly. So that's the buzzword for hydrocele. Sorry. Okay, testicular cancer is the last one. So it's a curable cancer of the testis, and unlike every other cancer that occurs later in life, this is a cancer that occurs early in life. Okay, so the ages about 15 to 35, and yeah, and then it's like a firm mass that happens that occurs in the testicles, and like it's common to have family history or some of the other risk factors like Klinefelter. Cool. So with that, oh, and then like the tumor markers for testicular cancer is going to be AFP, alpha fetoprotein, and beta HCG. So if you got like those diagrams we talk about a male that's pregnant, so they want to think of testicular cancer. Okay, cool. With that, I've come to the end of. Any questions? Sure. Any questions? No? Okay. So thank you and good luck for the exams. And
Thanks, I couldn't make it. There's food outside if you want to go to the front there.
okay, that's okay.
Thanks so much, man. Appreciate it. Sorry for jumping up and down.
No, that's fine.
Just stop sharing now.
Yeah, that's all good.
No worries.